I'm impressed at how many people are here so late and at the very end. So I thank you, I respect you. I was asked by Dr. Beltatine, he said, can you tell everybody in the audience everything they need to know about pediatric pulmonary in 1 hour? And I said, oh, I can do this. It's easy. And I thought, you need to take oxygen in, you need to get carbon dioxide out. Muchas gracias, buenas noches. But then I said that really wouldn't work, and so I'm going to give you a very fast tour of lung diseases in children. We've already had an excellent talk by Dr. Gutierrez about asthma and asthma control. Asthma is the most common chronic inflammatory airway disease. It affects millions of people around the world, about 7 million children in the United States, with many hospitalizations, and we're seeing even more this time of year with the rhinovirus precipitating. In fact, rhinovirus is the most common precipitating factor for an acute asthma attack in both adults and children. The prevalence is increased by about 40% in all ages. It usually develops in childhood, so that almost half of the children by 3 years of age and most before 8. Although under the age of 3, there are many things that wheeze that are not asthma. It's more common in boys than in girls until puberty, and then after puberty, and particularly in adults, it's more common in women. And you've seen pictures like this where there is inflammation, which is usually type 2, particularly in children. This is allergic inflammation. But in adults, in people with obesity, in patients who have been on steroids for a long time, you can get a neutrophil dominant inflammation, or T17. Bronchoconstriction occurs intermittently and produces the symptoms of difficulty breathing. Airway inflammation is consistent. You get chronic mucus plugging, and in fact, patients who die of asthma die from drowning in their secretions. I have never had a patient in our intensive care unit die of asthma from salbutamol deficiency. So it opens the airways. You get remodeling, and this leads to this chronic bronchial obstruction. The diagnosis of asthma is history, history, history. There's no single test. Yes, you can ask about family history. You can look for allergies. You can see if it intermittently, all of these things are important, but it's the history. Family history, exposure, including exposure to tobacco smoke, troublesome cough, particularly at nighttime, coughing or wheezing that persists after activity, breathing problems during certain times of the year. And this isn't just allergies, but it's also in times when the patients get viral infections, and tightness after allergen exposure, colds that last for a long period of time, relief when you get asthma medication, and indeed lung function testing to see bronchial hyperresponsiveness. So the treatment is first to get the diagnosis correct, since there are many things that can produce shortness of breath. Avoid triggers, bronchodilators. We just heard all of these excellent talks, again by Dr. Gutierrez, who emphasized what we're emphasizing now, control, control, control. The key messages of both the National Asthma Education Program, GINA guidelines, and the guidelines you heard earlier are asthma control. We're seeing the use of inhaled corticosteroids intermittently with the single inhaler, or the SMART protocol, that gives the patients relief plus some anti-inflammation when they need it. Asthma action plans, written action plans, reviewing the plans help to reinforce the importance of taking medications. We really aren't looking very much at how severe the asthma is, because our goal is to make asthma less severe with control. And this requires follow-up visits and control in the home. The natural history of asthma, this is a very famous picture by a colleague from Brazil, showing that early wheezers tend to get better. This line here is your asthma, and certainly by the age of 3 and over, it's the most common cause of recurrent wheeze. but you can have non-atopic wheezing, and in the very young child, these viral wheezers do not develop long-term asthma. These early wheezers are associated with maternal smoking, RSV and rhinovirus, and it's usually better by age of 6. The late onset wheezer is usually after 3 years of age, and by 6 years they're atopic. And the atopic wheezer usually starts at about age 2 to 3, and then as they get better, they may actually reactivate when they are older. Changing again, congenital diaphragmatic hernia, the most common manifestation, it's 1 in 2,000 to 5,000 live births. Most are on the left side. You can get hydramnios, which is a very poor prognosis. These babies have immediate respiratory distress, both because they have their intestines or their liver up within their chest, but also because of pulmonary hypoplasia, and this in turn leads to pulmonary hypertension. Very bad. They can have diminished breath sounds or even bowel sounds, and the abdomen is very flat because the intestinal contents can be up in the chest. Pulmonary hypertension associated with hypoplasia and in some cases cardiac abnormalities are the most important things to consider here. So when a patient has a diaphragmatic hernia, they're stabilized and then surgery as soon as possible. Persistent pulmonary hypertension complicates most of these babies, and many will require extracorporeal membrane oxygenation, or ECMO. There are other thoracic abnormalities as well. Progressive neuromuscular disease can produce restrictive disease, and restriction means a low tidal volume as opposed to obstruction, which is low airflow. Pectus excavatum does not cause heart disease or lung disease. Surgery is cosmetic and is usually delayed until late adolescence. Thoracic abnormalities can be a manifestation of bone or pulmonary maldevelopment, both of which will lead to restrictive disease. And as you know, scoliosis is more common in adolescent girls. Other syndromes appearing early on, congenital lung malformations, used to be called CCAMs, sequestration, and things like that, are all grouped together now. Separate is the pulmonary AV malformation, as I spoke of the other day, which is a manifestation of hereditary hemorrhagic helangiectasia. I need some more Guatemalan coffee. And the testing as a dominant for the HHT1, again in family members. Lymphangiomyomatosis is more commonly seen in women of childbearing years. Curiously enough, the genetic defect in this is the same as that of tuberous sclerosis. Patients with tuberous sclerosis that present with epilepsy and the skin conditions, the tubers, also develop lymphangiomyomatosis. This is considered a low-grade malignancy. Genetic testing is important, and you can also diagnose it with an elevated serum VEGF type D. This is a picture of a newborn, it's an X-ray, who had a congenital lung malformation. As you can see, it's a huge cyst that's pushing the heart, pushing the lungs. This child required oxygen. The heart rate was a bit elevated, the respiratory rate was elevated, and the parents decided, we don't want to have surgery. So, if they say no, they say no. One thing you need to be aware of, this is associated sometimes with the development of cancer, pleuropulmonary blastomas. And those cancers are all associated with an abnormality of Dicer1. Even removing this doesn't reduce the risk because this abnormality exists in all cells. It can produce brain tumors, ovarian tumors are common, and it can produce tumors in the normal part of the lung. So just removing the abnormal portion doesn't decrease this. Furthermore, if patients do not have this abnormality, they're not at additional risk for developing cancer. Because this oncogene is autosomal dominant, if you identify it in the child, you also need to test the parents. So what happened to this patient since the parents said, we don't want surgery? Well, at age 4, the child had no symptoms, and this was the X-ray. This did not grow, but but the other lung did. And you can still see this is hyperlucent. There still is a shift, but it just wasn't growing with the child, and there was no evidence of the child having any impairment. So this large type 1 congenital pulmonary malformation didn't grow with the child, but they were able to support with this one lung doing the work of two. Apnea of infancy is an unexplained episode of breathing cessation for at least 20 seconds or a shorter pause with cyanosis, pallor, hypotonia, hypoxemia. Sudden infant death syndrome is the death of an infant that's not explained by history and which a thorough postmortem examination doesn't show a cause of death. We don't use the term near-miss sudden infant death syndrome because it implies that this may occur again. We're using the term brief, resolving, unexplained episode. It's an episode that's frightening. It's characterized by apnea, color change, muscle tone, choking or gagging, sometimes due to reflux or aspiration, but no other cause is identified. We've heard some excellent Feders told us about apneas, so I'm not going to go into this in detail. She's given us some outstanding lectures during this. But apnea in the newborn is different from periodic breathing, which is almost like Shane-Stokes, these clusters of breathing. Periodic breathing will spontaneously resolve, and it almost never is associated with hypoxemia, and it doesn't require treatment with caffeine. Central apnea, these are patients that won't breathe. Obstructive apnea, patients that can't breathe. Obstruction, you struggle. Central apnea, you just stop breathing. You can see it with drugs like barbiturates. You can see it with prematurity. You can see it with brain stem lesions or with things like congenital central hypoventilation syndrome or with severe anemia. The role of apnea monitoring for infants with apnea is almost zero. The apnea monitors that go home can misfire, they can keep the parents awake, and they rarely help you identify an apnea. So we are not using apnea monitors. If the patient requires oxygen because of hypoxemia, they go home with a pulse oximeter. I'm not going to talk about obstructive sleep apnea. We had a wonderful talk by Feders, and we're going to move on to pulmonary hypertension because that's one of the sequelae of obstructive sleep apnea with intermittent hypoxemia. It can be due to heart disease, airway disease, pulmonary disease, and drugs. It's potentially reversible with medications or with oxygen. I'm not going to talk about the electrocardiogram diagnosis, but the therapy includes oxygen for patients that are hypoxemic, one of the more common causes, and then there are specific medications like sildenafil, PD5 inhibition, endothelin receptor antagonism like bosentan, nitric oxide, and for very severe patients, prostacyclin analogs like iloprost, which can also be given by inhalation. I showed you pictures the other day of laryngomalacia. This is noisy breathing, usually beginning between 2 and 6 weeks of age, louder when active, softer in sleep, air swallowing, normal growth, rarely associated with tracheomalacia, so we don't use the term laryngotracheomalacia, and it resolves on its own. And for the severe patient with failure to thrive, a retinoplasty can be a benefit. This is tracheomalacia. You see the widening of the posterior membrane with the esophagus beneath, and you see a little bit of an indentation here from the innominate artery. Clinical manifestations of tracheomalacia in the newborn, failure to extubate. They're doing very well, but when the tube comes out, they obstruct their airways. In older patients, they can have a very loud barking cough. They can have failure to thrive, infections, and interestingly enough, salbutamol makes this worse because the one thing keeping this airway open is when these muscles down here tighten and the muscles around there. And when you relax the muscles, you get worse obstruction. Endotracheal intubation can cause subglottic stenosis, granulation tissue, particularly with deep suctioning, and acquired tracheomalacia. And now the most common cause we see of tracheomalacia are babies in the premature nursery who have been intubated for a period of time. It resolves over time. It gets better. And this, again, is subglottic stenosis right below the vocal cords at the narrowest part of the airway at the cricoid. This is severe and needs to be surgically corrected. Stridor is due to variable extrathoracic airway obstruction or fixed intrathoracic obstruction. I mentioned the cricoid is the narrowest part. Endoscopy is the tool of choice for laryngeal and vocal cord disorders, also for identifying a foreign body which can cause stridor. And you can sometimes see flattening on the inspiratory loop on inhalation. So this is a older patient with vocal cord dysfunction who develops noisy breathing with exercise. The expiratory pre and post-exercise were normal. Pre-exercise, an excellent inhalation, but after exercise, you can almost see the vibration of the extrathoracic trachea. This shows a decrease in the inspiratory portion and a high-pitched stridor. Croup, 2 to 4 day upper respiratory prodrome, low-grade fever, commonly in males up to 3 years of age, harsh cough except when they're very severely obstructed and aren't moving air. Only about 3% need hospitalization, and the chest x-ray typically shows the swelling in the upper airway with what's called the steeple sign. Bronchiolitis is a syndrome in infants who have upper respiratory tract infection. It's not a specific diagnosis. It's most commonly caused by respiratory syncytial virus, but RSV can also cause pneumonia and not bronchiolitis. These patients have fever, tachypnea, occasionally fever, difficulty breathing, more commonly crackles than wheezing. RSV infection doesn't necessarily mean bronchiolitis, and infection with other viruses can cause a bronchiolitis picture. The children that need to be admitted to hospital are those that are low in oxygen, that progress rapidly, that have underlying disease such as cystic fibrosis or spinal motor atrophy, or who are unable to get back to the hospital if the child gets worse. The appropriate management is suppurative. You give them oxygen if they're hypoxemic. You suction out the nose if the nose is obstructive. You let them feed, but you don't give them bronchodilators, antibiotics, saline, steroids, mucolytics, group tent, high flow, or fluid boluses. None of those help bronchiolitis. Wheezing, the differential diagnosis of recurrent wheezing, foreign body, asthma, airway abnormalities, vascular abnormalities which can compress the airway, pulmonary edema, small airways, which is associated with that viral wheeze of infancy, psychogenic wheeze, or a noise that the parent tells you is a wheeze that really isn't a wheeze at all. I showed this the other day. This is a vascular ring compressing the esophagus, which in turn is compressing the trachea, causing a wheeze. Exercise intolerance may not be pulmonary disease, and asthma is rarely the cause, and I showed you all of these the other day. And I also spoke of cough. The differential diagnosis of child cough includes chest disease, such as those that will produce bronchiectasis, postnasal drip or upper airway cough syndrome, commonly protracted bacterial bronchitis, which is a wet cough, usually in small children, that's resolved with using antibiotics, generally augmentin, amoxiclav. And you can see it with tuberculosis, pertussis, chlamydia, almost never due to reflux or asthma. The habit cough, on the other hand, is less at night. Sometimes there's something that brings it on, such as a respiratory infection, and it can be associated with tracheomalacia. When do we use medications for cough suppressants like guaifenesin? And the answer is never. Things that can make cough less effective include weakness, neuromuscular disease, thoracic deformities, pain with coughing, and airway collapse. These make cough less effective. Aspiration. Signs and symptoms of a foreign body, history is incredibly important, even though there may be no history. It usually is a sudden onset of cough while awake. And the story we often get is the child is in the back of the car eating, suddenly they start coughing, and they have a foreign body, generally food, down their airway. Food is not usually seen on an x-ray. So if you take an x-ray, you may see hyperinflation due to a ball valve or partial obstruction, but rarely will you see the food present in the airway. This will produce the shift and the wheeze with the hyperinflation on that side. When you suspect a foreign body, you need to look for the foreign body. Yes, you can do x-rays, but endoscopy is not only diagnostic, it's curative. And as I mentioned before, if you're worried about aspiration of a foreign body, a history is the most important thing. Recurrent aspiration can occur with swallowing disorders, and it's different from reflux. You can see it with weakness, cerebral palsy, dysmotility. Aspiration, while reflux can produce a cough, aspiration can produce bronchiectasis with the chronic infection and inflammation. And it can occur even in patients that have a tracheostomy. Cystic fibrosis, the most common life-shortening genetic disease, 70,000 patients worldwide, about 1 in 3,200 live births in Caucasians, about 1 in 13,000 in Hispanic Americans, about 1 in 17,000 in Black Americans, and about 1 in 90,000 in Asians. We see in the United States about 1,000 new cases a year. The way to diagnose it in most places now is newborn screening, which is mandatory across Canada and the United States. They will pick up about 80% of cystic fibrosis. The other 20% are not tested for. They test for the most common mutations. These patients present in the newborn period with bowel disease, with failure to thrive, with jaundice, with liver disease, with malabsorption and foul-smelling stools. Rarely do they present with lung disease in the first year of life. They can have rectal prolapse, steatorrhea, with long-standing disease, clubbing and nasal polyps, pancreatitis in the adolescent if they are pancreatic sufficient. Neonatal lung disease is rare, and wheezing is rare. Your classic CF with no CF proteins, such as delta F508, gives you sinusitis, chronic infection of the airway with bronchiectasis. Almost 30% have significant liver disease, and about 5 to 10% have severe disease, eventually requiring liver transplantation. Pancreatic insufficiency, about 15 to 20% have meconium ileus and high sweat chlorides, and they have azoospermia, male infertility. In those that have some functional, sinusitis and obstructive azoospermia are there. You have later onset infection, but generally you have usual pancreatic function. We're now doing genetic testing. Sweat testing is still very important, but genetics has become more important as we develop more treatments, the modulators that are specific for certain genotypes. So all patients now after diagnosis are genotyped in preparation for them taking these wonderful drugs. Newborn screening, and again, they initially are infected with Staphylococcus and Haemophilus, later with the gram-negative bacteria such as Pseudomonas, Steatotropomonas, Alcaligenes, Ralstonia, and the bad disease is caused by Burkholderia, multiply resistant staph, which is worse than Pseudomonas, and Mycobacteria abscessus. The cystic fibrosis transmembrane ion regulator controls bicarbonate and chloride movement in and out of the cell, and secondarily it influences water movement and with that hydration. So with chloride blocked, water doesn't move with the chloride, and the periciliary fluid here becomes dehydrated. This mutant CFTR leads to less airway surface liquid, poor mucociliary clearance, altered inflammatory response, which leads to obstruction, infection, inflammation, on and on until you get progressive irreversible lung damage. The goals in treating CF: get rid of the excessive secretions using airway clearance therapy and medications like pulmozyme. Control infection with antibiotics and immunomodulators to control inflammation. Improve CFTR function with the new modulators. Improve nutrition, which is key, using enzymes. High quality diet, fat-soluble vitamins for A, D, E, and K. Avoid exposure to smoking. Make sure they are immunized. Exercise and adherence to therapy are key. Primary ciliary dyskinesia can produce bronchiectasis, as well as immunodeficiency can produce it, and chronic aspiration. The causes of bronchiectasis, most common is CF in children, but as I mentioned, these can do it as well. And in patients that have swallowing problems, such as big tongue, Down syndrome, difficulty swallowing, we can see very significant development of bronchiectasis. You can diagnose it in a child with a chronic wet cough, underlying illness that would produce this, and high-resolution CT. If the patients have chronic draining ears and rhinitis and neonatal respiratory distress, this is probably due to primary ciliary dyskinesia. And bronchiectasis, the diagnosis of choice is high-resolution CT, where you see bronchial dilatation. You can see thickening of the bronchial walls. You can see bronchi that do not taper as you go peripherally. And you can see bronchi visible, very distal and close to the pleura. This large bronchi with a small blood vessel is referred to as a ring sign, almost like a little diamond on a ring. This patient this is thymus, but there's infection here in the left upper lobe. And you can see the liver is on the left side, and the stomach is on the right, the heart is switched. This patient has situs inversus totalis and primary ciliary dyskinesia. Closing up, cyanosis is not an indication, a good indication of low saturation. You actually need enough deoxyhemoglobin, usually 5 grams per deciliter. So if you're anemic and you have a hemoglobin of 10 grams per deciliter, you need to have a saturation of 50% or less to see cyanosis. You can have hypoxemia, therefore, without cyanosis. If you are seeing cyanosis, generally there's a problem. There are other causes, though, such as right to left shunt, methemoglobinemia associated with taking certain medications, and in the newborn, cyanosis is almost never due to lung disease, almost always due to congenital heart disease, with a right to left shunt sending unoxygenated blood back into the circulation. Just a few other syndromes: constrictive bronchiolitis, used to be called bronchiolitis obliterans. This is a diffuse progressive fibrosing small airway obstruction, irreversible, and it's often associated with graft versus host disease of the lung. Cryptogenic organizing pneumonia is not the same. These are two different diseases. This is restrictive, patchy in distribution, generally acquired after a severe respiratory infection, often due to something like adenovirus, and may respond well to steroids. So this is irreversible, poorly responsive to steroids. This is generally acquired and may respond. I spoke briefly about hemoptysis. You can get blood first from the nose or mouth that masquerades as airway bleeding, so you need to be sure that it's coming from the lungs. You can see it with diffuse alveolar hemorrhage, bronchial circulation bleed, which produces bright red blood, and you'll see this in patients with bronchiectasis. You rarely get hemoptysis just due to low platelets or a coagulopathy. There has to be some break between the blood vessel and the airway. And you can get painless hemoptysis with tuberculosis, and a foreign body can irritate the airway, producing blood. The initial management: secure the airway, identify and stop the bleeding, and give blood if needed. And this I showed the other day. These are iron stains in a patient with diffuse alveolar hemorrhage, idiopathic pulmonary hemosiderosis. Swyer-James syndrome. This is a small hyperlucent lung due to loss of both airways and loss of the vessels, often due to a very severe viral infection in infancy. Classically, it's been related to adenovirus, but it can be seen with other viruses. It was originally described after adenovirus. Alpha-1 antitrypsin deficiency. For this one, we call the gastroenterologist. It almost never produces lung disease in children. It does produce liver disease. In young adults, however, it can produce early onset basilar emphysema, particularly if they're exposed to tobacco smoke. It's diagnosed by protease inhibitor or pi typing, where the MM is considered normal and either SS or SZ or ZZ is deficiency. These patients are now being treated with exogenous alpha-1 antitrypsin. Pulmonary alveolar proteinosis. When you have surfactant apoprotein B deficiency, you have very severe disease, often fatal without transplantation. In older infants, you can see it with surfactant protein C deficiency or the adenine binding cassette A deficiency. Older children, again, with SPC, deficiency of the GM-CSF receptor. Now, the GM-CSF stands for granulocyte macrophage colony stimulating factor. It's the growth hormone that matures the macrophages. And when surfactant is circulated in, it's always being produced by the type 2 cells, but the macrophages in the airways will ingest it and recirculate it. If you're an adult with antibodies to this, the macrophages don't mature. If you're a school-age child that has a receptor abnormality, the same thing happens. And then there's a whole group of childhood interstitial lung disease. Commonly seen includes knee-high neuroendocrine hyperplasia of infancy, and that can be diagnosed by CT scan. We have pulmonary interstitial glycogenosis, and these often resolve with time. And again, older children with SPC deficiency can have classic interstitial lung disease. And I'll end up talking about testing very briefly. Pulmonary function testing, we usually mean spirometry. Restrictive disease is a low vital capacity, and that is associated with weakness, pain, drugs, space-occupying lesion. Obstructive disease is low airflow. FEV1 is typically what we measure, the amount of air you can force out in 1 second. And if this is lower than the vital, in restrictive disease, both of these are low, but they're equally low. So you'll have a vital capacity of 60% and FEV1 about the same. That's restriction. Obstruction, you tend to have a fairly normal vital capacity, and, oops, I did it again. I was very good for a while. A low thing. And you'll see this with asthma CF. And we usually don't very often measure peak flow or mid-air flow. We can also get static lung volumes or gas washout to look at the very small airways. We can get look for communicating gas, and we can look for trapped gas, increased residual volume in the body box plethysmograph. Pulse oximetry. Love this. Some people have referred to it as the 5th vital sign, but you have to be sure that the data you're getting are correct. We see, sometimes older children, and because they had it around their foot in the nursery, they put it around the foot in a 2 or 3-year-old, and it doesn't pick up because you don't have a good contact between the light and the reception. So it has to have good perfusion, a good pulse segment, and proper placement. It won't recognize obstruction until too late, and it doesn't recognize high CO2. Atelectasis, X-ray of the chest with a density that moves the heart and the mediastinum toward the density. It decreases volume, whereas pneumonia increases volume, pushes things away. The same thing with parapneumonic effusion, pushes things away. So the shift is toward the density, and there may be air bronchograms, and you can do a chest ultrasound for pleural-based lesions like a parapneumonic effusion. I talked about sweat testing briefly. You can get false positive sweat tests if the sweat evaporates, which concentrates the sweat. Support technique, anorexia nervosa. Important to know, you have an adolescent who is very thin. She comes in with a cough. You cannot rely on the sweat test until they're renourished, and if the skin is broken down. When do we do a bronchoscopy? Unexplained airway problems, not interstitial problems, not problems within the lungs, but within the airway. Unexplained cough, recurrent stridor, wheezing, pneumonia, particularly in patients who are immunocompromised. One of the most common reasons we do it is in our bone marrow or stem cell transplant patients. Failure to extubate, worrying about malacia and airway collapse or granulomas, and to obtain culture for diseases like tuberculosis. And I did it in less than an hour. We have time for cocktails. And before I thank you, I want to thank our incredible AV staff. You guys have been phenomenal in helping us out and making sure this ran correctly. I bow to you. Yes, sir.
Again, thank you for a nice talk. I want to ask you, in cystic fibrosis, how often do you see wrinkles of the hands? In Spanish, arrugamiento de las manos. How often do you see? The common is because a group is doing the immersion of the hands and in school children, and if they have wrinkles of the hands, they go to sweat test.
I understand that's actually been published, and even the carrier may have earlier wrinkling. The problem is almost anybody with enough water, with enough time, will develop wrinkling, particularly if you, what he's saying is that in CF, because of the fluid secretion that you get, you end up, you know how when you're in the water, sometimes the fingers end up with all these wrinkles, like on my face? That's more common in cystic fibrosis. It occurs earlier, and it also even occurs in the heterozygote. I don't think it's accurate enough to exclude the disease or to include the disease. It's a very interesting phenomena. If the parent mentions, it's like kissing and seeing if they taste salty. If you do taste it, then you think about it, but there are other things that can cause salt and sweat, and not everybody comes in with sweat. So interesting phenomena, doesn't replace the sweat test.